I'm joined today by Dr. Jeff Szymanski, who's currently the executive director of the International OCD Foundation. Jeff was previously the director of psychological services at McLean Hospital's OCD Institute. He's also author of the book, The Perfectionist's Handbook, and serves as a clinical instructor in psychology at Harvard Medical School. So, Jeff, let's start sort of at the top. When we talk about OCD, obsessive compulsive disorder, there's a lot of sort of layperson's terms that are thrown around about what that is and what the symptoms are. But what are we talking about when we talk about OCD?
Yeah, so in the way that you just said, the best place to start is to define some of those terms. Because the way people use, for example, obsession in lay conversation is different than how we use it in psychology and psychiatry. So obsessive in general conversation means I'm obsessed with my favorite baseball team. I'm obsessed with the color purple, meaning I really like something. That's how we use it. When we use the word compulsive in everyday language, we're talking about people that are neat, people that are people that are very detail oriented, people that are perfectionistic, right? So the problem with those two terms in lay language, having the same words in the title of OCD is that everyone gets them confused, right? So they say, oh, I'm a little OCD because I'm obsessed with having my sock drawer compulsively arranged. And so what happens for people with OCD is they hear that and they're like, oh, you just don't really understand or get my experience. Because in the context of obsessive compulsive disorder, obsession means unwanted, intrusive thoughts and images, things I don't want to be thinking about, things I don't want to be seeing in my mind. And they create a lot of unwanted feelings, primarily anxiety, but also guilt, disgust, other kinds of feelings that a person with OCD doesn't want to have. So these obsessions actually turn up in a lot of frequency and a lot of intensity. And so as the anxiety increases and the unwanted feelings, the unwanted thoughts increase, the person feels compelled to engage in compulsive behavior. Now, the compulsive behaviors are repeated behaviors you're doing internally. So it could be counting or praying or saying a good word over and over again in order to keep yourself safe. Or it could be external behavior. So a lot of people have seen the cleaning and hand washing, et cetera, but there's a lot of different kinds of compulsions that can range from having to do things in a certain number of times or also just kind of avoiding certain situations that would evoke the obsessions and the anxiety. So the difference between someone being obsessed with their baseball team and someone having OCD is that someone with OCD actually is suffering on a day-to-day basis. And the anxiety and the obsessions and the compulsive behavior are time consuming and they're getting in the way of day-to-day activities. So people are showing up late to work or they can't work. They can't get their schoolwork done. They're not being able to see family members or friends that they'd like to be able to see. So again, the D in OCD stands for disorder, meaning that the person's day-to-day functioning is significantly impaired.
How prevalent is OCD in the sense that you're describing it in American society, world? I mean, do we have, probably world is tough because there's so many countries where we just really wouldn't have data, but maybe in the US?
So in the US, this has been shown several times that at any given point, about 1% of the adult population has OCD, and which translates into about 2 to 3 million adults right now would qualify for an OCD diagnosis. Another 500,000 to 1 million kids would also qualify for an OCD diagnosis. In fact, we do have a number of studies worldwide, and that same prevalence of OCD stays consistent across country, that it's about 1% of the population.
Now, that's interesting where you say it's consistent across countries, because one of the things I wanted to discuss was whether OCD is a sort of modern Western condition, in the sense that if we were to go back 100,000 years or something like that in human history, do we know anything about the prevalence of OCD or something like it? Or is it really something that has been sort of created or a result of modern Westernization?
So we know from neuroimaging studies actually that there are some brain abnormalities for people that have OCD. We know from genetics research that about 1 in 4 kids that have a parent with OCD will have OCD.
Hmm.
So there's a genetic transmission, there's a neurobiological component to this. The way that people have talked about OCD and other mental illness historically is looking at autobiographies that people wrote, or biographies where people had written about them. Vincent van Gogh, I think, was an example of someone who likely suffered from bipolar disorder. So the idea that it's a modern kind of a modern manifestation of something about our society, probably not so much. I think mental illness has been around for quite a while, and to this day, what we still hear people say is, "I had OCD for many years. I just didn't have a name for it. I didn't know what it was." So I think that was the case historically, is that someone was behaving in an odd way and reporting being very distressed, and they just didn't have a name for it.
You talked about some of the examples of what are actual OCD symptoms. Are there examples of symptoms attributed to OCD that aren't really OCD symptoms?
I think it probably goes in the other direction, where a number of people in our community find is that they were misdiagnosed with something else rather than OCD.
Hmm.
So, for example, some people with OCD will have violent thoughts, and they're thoughts that they don't want to have. It isn't, "I had a thought of harming someone and I think I might do it." It's the exact opposite. They're so concerned that they had the thought that they now start policing their mind. "Oh my goodness, if I have this thought again, this is a terrible thing. I'm a terrible person." And then they start engaging in all this compulsive behavior to make their mind not think these thoughts.
Hmm.
Again, they're not a violent person. They've never committed any violence in the past. And so what happens is that their compulsive behavior increases. They go and report this to a mental health professional who may not know about this form of OCD, and they start to think of them as a potential violent risk. Same thing with sexual thoughts. There's some people that have unwanted sexual thoughts. And if they go to a mental health professional who doesn't know anything about OCD, they might think, "Oh, maybe this person has some sort of sexual disorder, or maybe they're at risk for harming other people." And so we don't have so much other things get confused with OCD. It's that OCD actually gets uh, uh, not thought of and misdiagnosed quite frequently. A lot of folks that I worked with would be diagnosed with psychotic illness like schizophrenia, because sometimes the obsessions can be very bizarre. But the person knows that the thoughts are bizarre, and that ends up being one of the primary differences.
What constitutes treatment for OCD? Can it be treated effectively? Are pharmaceuticals the answer? Is it something else?
So, unfortunately, the recent research is showing it takes somewhere between 14 to 17 years between onset of OCD symptoms and actually accessing effective treatment. And one of the many problems with that is that there is effective treatment. And so there's a class of medications called selective serotonin reuptake inhibitors, more commonly thought of as antidepressants, but they have anti-OCD properties as well. And so for many people with mild to moderate OCD, they go to the psychiatrist or primary care physician. If they've been diagnosed with OCD and they get on an SSRI, that might actually be the treatment of choice for them. There's lots of research showing that these medications can be helpful for OCD. However, the primary treatment that we refer people to is called exposure and response prevention therapy. And I liken this to if you know someone who's afraid of dogs, what's the best way to get someone over their fear of dogs? You have to expose them to being around dogs. So it's basically the same, kind of in an oversimplified fashion. It's basically the same idea with OCD, is that we actually have the person purposely think about the obsessions and put themselves in contact with situations that would evoke anxiety. And then we ask them to not engage in the compulsive behavior. And so when you break that link of having anxiety and then responding to it with compulsive behavior, and you now kind of cut that off, what happens is the person will continue to experience the anxiety. And what your brain does then is says, "Oh, wait a minute, this thing that I categorized as possibly dangerous maybe isn't as dangerous as I thought it was." And so then your brain starts to decrease its anxiety. And so we call this habituation. And so you get used to being in a certain situation. And over time, if people use exposure response prevention therapy, they expose themselves to anxiety in situations that evoke their obsessions. They don't engage in the response prevention is they don't engage in the compulsive behavior. What they find is that their anxiety over time decreases and they can approach more situations.
Absolutely fascinating. The book is The Perfectionist's Handbook. We've been speaking with the book's author, Dr. Jeff Szymanski, who is currently the executive director of the International OCD Foundation. Thanks so much for talking to us about this.
No problem. Thank you.